COVID-19 outbreak, pre-hospital and emergency care. Contents: Introduction, Definitions, General precautions, Patient dispatching and transport to hospital ER, Dispatch and call management, Dispatch pre-arrival instructions, Arriving on scene, Management during transport, Pre-arrival hospital notification, Post-transport management, Emergency room department, ER facility, designated locations, Healthcare worker protection. As outbreaks of COVID-19 develop, pre-hospital workers and other emergency responders may potentially be exposed to the disease through patient contact or through contaminated environments. Pre-hospital and ER setting are unique settings associated with a distinct set of challenges, including uncontrolled pre-hospital environments, transportation in an enclosed space, and hospital's front door. Definitions: EMS, Emergency Medical Services, or Civil Defense. MOH, Ministry of Health. PUI, Patient Under Investigation. HCW, Healthcare Workers. Patient dispatching and transport to hospital ER. Dispatch and call management. Every caller reporting a patient with possible COVID-19 signs or symptoms must be screened further during the call. Assessment of illness severity. Life-threatening symptoms include chest pain, difficulty breathing, or altered mental status. Advanced life support ambulance activation for cases of severe disease. Stable patients may be transported by BLS providers or an alternative means of transport. At the time of activation, dispatchers should inform the responding EMS crew of the patient's illness or symptoms and concern for COVID-19. Once notified, responding EMS will take appropriate precautions and prepare for the treatment and transportation. Dispatch pre-arrival instructions. Family members or first responders may assist in facilitating easy access to the scene and preparing the patient for transport. Apply available PPE to patients and family member. Maintaining a distance of 1 meter, they should isolate the patient from others. Direct EMS to the location of the patient. Prepare patient for dispatching, medications, medical reports. Arriving on scene. Upon arrival to patient, don appropriate PPEs to all team depending at the level of contact with the patient, driver, provider. Check table 1. At a distance of at least 1 meter, they should attempt to detect if the patient meets COVID-19 criteria. If assessments indicate COVID-19, appropriate PPE must be donned prior to further evaluation. If there is no significant concern for COVID-19, precautions may be adjusted according to the symptom. Aerosol generating procedures. Aerosol generating procedures in pre-hospital care include bag valve mask, ventilation, oropharyngeal suctioning, endotracheal intubation, nebulizer treatment, continuous positive airway pressure, CPAP, biphasic positive airway pressure, BiPAP, resuscitation involving emergency intubation, cardiopulmonary resuscitation, CPR. On scene, direct contact with the PUI should be limited to the least number of personnel possible. Appropriate PPE should be maintained all times. Provider should maintain a distance of at least 1 meter from the patient and should wear gloves to guard against infectious agents on the surfaces of objects close to the patient. Management during transport. Ambulance ventilation. Maximizing a high volume of air exchange by opening the windows and vents and setting all climate controls to fresh, not recirculating air. If separate, this applies to both the driver and patient compartments. Ambulances without separate compartments may create a negative pressure in the patient's area by opening the outside air vents and turning on the rear exhaust ventilation fans to the highest setting. During transport, limit the number of providers in the patient's compartment to essential personnel to minimize possible exposures. Family members and other contacts of patients with possible COVID-19 should not ride in the transport vehicle if possible. If riding in the transport vehicle, they should wear a face mask. Patient care during transport. Minimize patient contact during assessment. Provider may conduct patient stability assessment only. Defer obtaining vital signs if patient appears stable, has no visual evidence of distress or shock, and transport time is not prolonged. Any patient belongings should be considered contaminated, placed in a biohazard bag, sealed and labeled. Pre-arrival hospital notification. The receiving facility should be notified as soon as possible of the arrival of a suspected COVID-19 patient. The pre-arrival notification should indicate that additional precautions are required. It should also confirm the patient's clinical condition and physical condition. Post-transport management. Before doffing PPE, EMS providers should transfer waste from the vehicle to appropriate destination according to Institute protocol. Transport team should not leave the designated hot zone until PPE is doffed per protocol in the designated doffing area. If ambulance personnel are performing ambulance disinfection, they may proceed with disinfection prior to doffing. Cleaning EMS transport vehicles after transporting. Leave the rear doors of the transport vehicle open to allow for sufficient air changes to remove potentially infectious particles. When cleaning the vehicle, EMS clinicians should wear a disposable gown and gloves. A face shield or face mask and goggles should also be worn if splashes or sprays during cleaning are anticipated. Clean and disinfect the vehicle in accordance with the standard operating procedures. All surfaces that may have come in contact with the patient or materials contaminated during patient care. Clean and disinfect reusable patient care equipment before use on another patient, according to manufacturer's instructions. EMS agencies should develop sick leave policies for EMS personnel. Emergency Room Department. Develop or review your facility's emergency plan to include COVID-19 management in ER. Establish relationships with key healthcare and public health partners like MOH and Civil Defense. Staff training about COVID-19 and management in ER and related special protocols with simulation drills. ER facility, designated locations. Early detection checkpoints. For all persons, enter the hospital, not only patients. At all hospital entrances and ER entrance before triaging area. Trained nurses to detect COVID-19. With good ventilation. One-way direction, in-out. Staff wearing appropriate PPEs. Specific checklist to identify suspected patients. Specific protocol on how to handle suspected cases. ER triage area. Special isolated designated triage area. Reduce the amount of time patients are in the triage area. Well-ventilated area. Limit the number of accompanying family members in the waiting area. Triage area, including respiratory waiting areas, should be cleaned at least twice a day and after each patient with a focus on frequently touched surfaces. patient stations separated at least 1 meter distance, dedicated toilets and hand hygiene stations. Provide paper tissues, alcohol-based hand rub, and trash bin with lid. Patient should wear PPEs all times. Follow triage protocol that is adapted by the hospital. ER waiting areas. Special isolated designated waiting area for patients' companions. Well-ventilated area. Seats are separated at least 1 meter distance. Provide paper tissues, alcohol-based hand rub, and trash bin with lid. Patient and companions should wear PPEs all times. Dedicated toilets and hand hygiene stations. Healthcare worker protection. Providers must be well trained on special management protocols and precautions. Adhere to standard precautions and COVID-19 protection precautions. Have COVID screening when contacting with confirmed cases. Follow triage protocol. Additional considerations for triage during periods of community transmission. Begin or reinforce existing alternatives to face-to-face triage and visits such as telemedicine. Designate an area near the facility, for example, an ancillary building or temporary structure, or identify a location in the area to be a respiratory virus evaluation center, where patients with fever or respiratory symptoms can seek evaluation and care. Expand hours of operation, if possible, to limit crowding at triage during peak hours. Cancel non-urgent outpatient visits to ensure enough healthcare workers are available to provide support for COVID-19 clinical care, including triage services, critical or urgent outpatient visits, for example, infant vaccination or prenatal checkup for high-risk pregnancy, should continue. However, facilities should ensure separate or dedicated entry for patients coming for critical outpatient visits to not place them at risk for COVID-19. Consider postponing or canceling elective procedures and surgeries depending on the local epidemiologic context.